Hello everyone, this is CrISPP in MRCS OSCE. We have about 3 cases or 4 cases comes in different ways. But trust me, you need to do the following. You need to make sure that you are able to identify whether this patient is going to be critically unwell or no. So first case is a post-operative orthopedic case and major hip surgery, and the patient start to desaturate, to have hypotension, to have anything. So apparently you have been called by the A&E, by the nurse, and saying that the patient is snoozing in the ward, news of 5, news of 3, he's hypotensive, or he's tachycardic, or he is desaturating after major orthopedic surgery. So what are you going to do is, you will go and say like this to the examiner. You are not going to touch anything. You just need to tell the examiner, sir, I'm really concerned about major post-operative complication, surgical and non-surgical. Non-surgical, PE, MI, pneumonia. Surgical would be collection or surgical site infection. So it would be appropriate if I start assessing my patient using ABCD approach, care of the critically ill surgical patient protocol, ABCD approach. Is that all right? I will say go ahead. Oh, but maybe I touch him in the hip. No, you don't need to. If you don't believe me, do whatever you like, whatever you have. But believe me, it is the same case. Like this case have come many times over 5 years now. So airway, breathing, circulation, we've done. This is case number 1. I will tell you what is next. But this is scenario number 1. It is identifiable that it is CrISPP approach. Case number 2, major abdominal surgery, post-operative day 1, day 2, day 5, whatever, after any bowel resection anastomosis. If the case is unclear, is vague, he didn't say perform a classic abdominal examination, number 1. So vague case, major post-abdominal surgery. What are you going to do? Again, CrISPP. You will tell the examiner, sir, I'm really concerned about major post-operative complications for this patient, surgical and non-surgical. Surgical, anastomotic leak, collection, surgical site infection, non-surgical, PE, MI, pneumonia, urinary tract infection. Okay, so it would be appropriate if I start assessing my patient using ABCD approach, CrISPP protocol, and so on. Case number 3. So orthopedic, abdomen vague, abdomen hypotensive, feverish, or tachycardic or tachypneic, desaturating, also you will do with CrISPP. This is scenario number 3. Okay, so abdomen vague, not clear, do CrISPP directly. Abdomen, already I will touch the patient if say, okay, patient is having abdominal surgery and PE, and he will not say to you. Because some people went and say, already the patient not having pain. I told you before, the patient will not have pain. You are squeezing his tummy to say, but he will not because he got PE, not abdo pain. Okay, so case number 1, orthopedic, CrISPP directly. Case number 2, abdomen, vague, not clear. He didn't say anything. He say, assess your patient, use CrISPP. It is good to be safe registrar rather than do abdomen classic, and then you will discover this patient at the end of the station could be. Case number 2, abdomen, post-operative, and having any parameter of hemodynamic instability. Hypotensive, tachycardic, tachypneic, feverish, whatever. Okay? Desaturating. So this is case number 3. Case number 4, abdomen, exam, and he told you like this: please perform classic abdominal examination. So please follow the STEM. In scenario number 4, please post-abdominal surgery, please perform classic abdominal examination. So my colleagues, please go and do abdomen from the end of the bed, blah, blah, blah. Try to accelerate the general and start do the light palpation. Oh, the abdomen is all rigid and tender. Then tell your consultant, I'm really concerned. This patient is peritonitic. I'm really concerned about major abdominal. Sorry, convert it to CrISPP. Otherwise, if the abdomen is soft, non-tender, mildly tender in one area, and it's not peritonitic, continue abdomen. Okay, this is the best way for CrISPP because there are different courses in the market teaching a lot of stuff. I have done CrISPP. I told you before, it's not they need to do their CrISPP to understand, because if you are saying I will do first CrISPP and then the patient say, sorry, I will do abdomen, and if the patient is peritonitic, I do CrISPP, that's not fine because the patient might have PE. But if the examiner told you from the beginning, please perform a classic abdominal exam, then proceed with abdomen. That's end of talk. So again, you have four cases. Four cases. Case number 1, perform abdomen exam. Patient with post-operative orthopedic surgery, major orthopedic surgery, and patient started to desaturating, hypotensive, or whatever, the case will be CrISPP directly. Case number 2, abdomen vague. He didn't tell you anything. CrISPP directly. So major post-abdominal, post-op abdomen surgery, major surgery. Vague case, he just said assess your patient without any hemodynamic instability. Please be a safe registrar and do your assessment using CrISPP. But Reda, it was abdomen. He will tell you that's good from you, that you are expecting that this is potential hazard or potential critical unwell, but just do abdomen. He will direct you if it is abdomen and you are doing CrISPP, but not vice versa. Because vice versa means that you are unsafe. Case number 3, major abdominal surgery post-op in the ward, and the patient started to have hemodynamic instability, hypotension, tachypnea, tachycardia, fever, desaturation. Then please perform CrISPP directly. Case number 4, last case, abdominal surgery, that's fine. I'm not afraid about this. And just assess your patient, perform a classic abdo exam. Please proceed with the abdominal exam. Once you find the patient peritonitic, which is guarding, rigidity, tender all over, okay, like this, then revert it, say, I will not continue doing the classic abdominal examination. Patient is really peritonitic. I need to assess the patient using the safe approach of CrISPP protocol, ABCD approach. Well done. But if not, if you just mild tenderness, continue your abdomen exam. Are you convinced? And if you are not convinced, what should I do? I don't have anything in my hands. I told you what I will do for myself. Believe me. What else? Yes, that's it. Okay. So 4 stuff, 4 cases. And now I will tell you how to do the care of the critically ill surgical patient. You will tell the patient, hello, hi sir, how are you? How are you doing today? Doctor, I don't feel well. Okay, this session is interactive. Unless the examiner is not happy, so you do it silent. Oh, I will look, listen, feel, look for the presence of central cyanosis, listen for the abnormal sounds such as grunting, feel the airflow while on inspiration and expiration. Patient, no need to say that if the patient is communicating. Once he said, oh, doctor, I don't feel well, Apparently, airway is patent because the patient is communicating with me at the minute. I will start giving high flow oxygen, 12 to 15 liters per minute, via not preferably humidified via non-repressible mask reservoir bag, ensuring that the patient is not COPD. Otherwise, my target of the oxygenation would be 88 to 92. So I will give him 2 to 4 liters per minute via Venturi mask, ensuring that the saturation or the Venturi concentration is 28 to 32. I will proceed to breathing. I will look for use of accessory muscles of expiration, respiratory rate, equality, and depth of respiration. And I will ask my nurse, please connect pulse oximetry to get oxygen saturation. What is the oxygen saturation? Your consultant will tell you, apparently. If it is a proper consultant communication, he will tell you 88 or 91. So, and don't forget, in airway, you give oxygen. Don't worry. You will not over-oxygenate him. Just give oxygen. All ATLS patients should receive oxygen in A. All CrISPP patients should receive oxygen in A. Okay? So it's apparently ABCD approach, which is the same for all patients, but sometimes it's called ALS, sometimes it's called CrISPP. It is the same, but with focusing on some parts. Breathing, look, assess the respiration, ask nurse to connect pulse oximetry to go to oxygen sats, listen for noisy breathing, and auscultate for abnormal breath sounds, heart sounds, and their rhythm. Feel for equality of chest movement, trachea centrality, and the presence of surgical emphysema, and paradoxical respiration, whatever you can add. And I will percuss also the chest superolaterally, and I will talk to medics if needed and get a portable erect chest X-ray. Portable erect chest X-ray. Okay. A, B, done. Then circulation. I'm now going to move to circulation. I will ask the nurse to connect BB cuff to get blood pressure reading. I will assess both central and peripheral pulses, like for example, radial or brachial and femoral pulses, or radial and femoral, for rate, rhythm, quality, equality, volume, character. I will secure adequate venous access via bilateral 2-gauge, like 216 gauge cannulae. Send off bloods for, you should say it, full blood count, use and ease, CRP, LFTs, amylase, glucose, clotting profile. Last time they asked Hassan in Pakistan, what else in the blood you sent? He just missed the word coagulation profile and the group and safe. So clotting profile, group and safe, cross match 4 units, and if required, measure hemorrhage protocol for backed RBCs, FFPs, and the platelets. And I will ask for VBG for lactate or ABG to assess respiratory function as well. Rapid fluid challenge, giving stat dose bolus of warmed crystalloid of 20 ml per kg if hypotensive, 10 ml per kg if normotensive, and 5 ml per kg if any cardiac element or any element of heart failure. Okay, so blood pressure reading and pulse. Then IV access. Send off bloods and give fluids. Then check capillary fill time and signs of overt or covert hemorrhage. And check lines, tubes, and the drains for nature and the volume of the drains. Insert urinary catheter, and patient should be MPO if you are planning surgery, or you need input and output monitoring, the patient vomiting, so NG tube, total input and output charts, and ECG. If the patient septic, then surviving sepsis X bundle should be, which is give 3, take 3, you have given oxygen, you have given IV fluids, and give broad spectrum empirical antibiotics according to the local hospital guidelines. Check lactate, and send surgical site, if appropriate, blood culture and urine culture. So surgical site swab for CNS, culture and sensitivity, blood and urine culture, urine output monitoring, and ECG. That's I have added them, but ECG I have just added. Okay. All right. That's it. So this is the circulation. So I divided by colors just for myself and for you as well, if you want. Dysfunction of CNS, GCS is not needed. Then FPU, which is patient is alert or just he is alert to verbal stimuli or responsive to painful stimuli or unresponsive. Then blood glucose, and then check recent medications given, including sedatives, analgesics, or anesthetic drugs, and ensure patient pain is well controlled as well. And then exposure, I will ensure patient is adequately exposed, have no ensuring patient dignity, and his temperature is preserved, no fever and no hypothermia, using warm blankets if required, head-to-toe exam, TEDS in situ, wound check, is it a dry, clean wound, dry dressing, quick abdo exam assessing signs of peritonism, surgical site infection, bowel sounds, distension, and if you need to add these, but I don't feel they are essential, herniorrhaphesis, inguinal-scrotal and digital rectal exam are not that important. And then you need to tell your patients, after I finished, I need first, before I decide on the plan, check the charts, including medication charts, fluid charts, antibiotic charts, anesthetic charts. Tomorrow I will show you from the ward the news score of a real patient, and I will give you the fluid balance of a patient, and I will give you a full file just to have a look. Notes, op notes, recent scans, endoscopy, and performance status. This is very important. So check charts, very important. Check notes. Why? To know operative notes. Recent scans done, recent endoscopies done. What is the performance status? So you have anastomotic leak, but the patient is barely went to this surgery and his performance status is very bad. He got a lot of comorbidities, so he's not fit for re-laparotomy. Check GB records, perform full history taking and full physical exam. So charts, notes, GB records, history examination. Then decide on the plan. Patient stable or no? Apparently patient, you harvest the news. He told you that these charts showing that this patient, for example, is having his antibiotics, his TEDS in situ, and his low molecular weight heparin, enoxaparin, dose is done. Op notes showing that he went uneventful, uncomplicated surgery. But then when you asked about the news score, okay, the news score told you that this patient is actually having a news of 5 for saturation of 93 over 2 liters oxygen, and he is having hypotension. So now the patient is unstable. So I would have specific investigation to target specific diagnosis to manage it immediately, even overnight. So apparently this is abdominal surgery post-operative. So I have surgical and non-surgical causes. Surgical are anastomotic leak, surgical site infection and collection inside the abdomen. So, or non-surgical like PE, MI, pneumonia, urinary tract infections, maybe most probably abdosepsis query cause. So I need to escalate to my consultant. And so S scenario identification, P prioritization. You have seen this patient by yourself as a registrar, senior registrar, and you have done initiative, which is ABCD approach, and then and then E escalate to your consultant, and you have spoken to radiology consultant for CT abdo-pelvis with contrast, ensuring the patient got no contrast allergy, and the eGFR is reasonable, above 50, above 30 is fine. While resuscitating the patient is ensuring that the patient is stable, CT urgent timing slot confirmed, booked, and documented. Okay, early involvement of my consultant, because he is apparently anyway they will attend it. Okay, inform theaters, organize local entity overnight, including discussion with ITU whether post-operative ITU required and bed availability, liaise with the anesthetist for review for this patient in terms of fitness for surgery and perioperative optimization if required, using, so I will discuss with you. Consultant, theaters, done, okay? Then ITU registrar to define if this patient needs ITU or no, and bed availability, okay? Then anesthetist to define the fitness of surgery for this patient. Is he fit or no? Using what? Using his frailty, performance status, comorbidities, PPOSM, and NELA score. PPOSM is for mortality and morbidity, and NELA score is part of, POSM is part of NELA. NELA is national laparotomy, blah, 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 audit for laparotomy. Okay. Update the ward staff nurse. This is very important. So it is part of your professionalism and part of your closed loop communication to talk like this. Okay, not like, okay, patient have query anastomotic leak, CT abdo-pelvis, CT with or without contrast. They will comment like this. With contrast. Okay, patient got contrast allergy. And then you will start. But if your answer is complete, you will never be prompted. What's the promption? You know what's prompting? If the examiner stopped you and advised you, he's not, I'm sure he's kind because we are live, but he's prompting you. Prompting means he's advising you, he is directing your answer. So he will deduct marks for prompting. This is for any interview. Like if you are not, if he's sleeping at home or he is having surgery in theaters and you need to have decisions. So who will guide you? Yourself. But you are deficient because you need someone to tell you, have you asked about EGFR? Have you asked about contrast allergy? Like this. Is CT abdo-pelvis non-contrast or with contrast? So you need to give one answer like this one, previous one. Yes. So abdo-sepsis, query cause, I will call the radiology, CT abdo-pelvis is contrast, ensuring no contrast allergy, EGFR, one go. Okay. After you finish your liaison, you need to manage the other half of the movie, the patient. Explain findings and management options. So the patient, patient's next of kin. Already, would we find time for this? If you don't have this in your mind and you have time, what are you going to say? Okay, so keep these sentences in your mind just to say them. I know some of you are registrars and eligible to be registrar, and they know what these talks, but please keep them. They are important. This is a purified, good, discipline findings, management options to the patient. Patient's next of kin have a joint decision in the patient's best interests. And also, I will assess the patient's capacity. If the patient got capacity, then I will do consent form 1 if he's going for surgery. If no capacity, then consent form. This is called the complete answer. Consent form 4 is with 2 consultant signature, ensuring that there are no advanced directives. What are advanced directives? Decision made by the patient. Yes, that's good. So me as a patient, I wrote a paper, legalized paper called advanced directives, pre-written document saying that when I have accident, I don't want to be having laparotomy. I don't like it. So when I have splenic injury or intra-abdominal bleeding, with this advanced directives, later on in the future, no one will touch me. So they are legal pre-written papers for the patient future wishes. Okay. And there are no lasting power of attorney for health. What is the lasting power of attorney? توكيل in Arabic. I know, like, you know, you are my brother and you are responsible for my health while I'm dying or while I'm comatose. Okay. So, for example, he is representing me legally if I have anything illness. So he will say, no, don't do anything for him. So what should be done already? Any adult responsible for his life or death. So if you have adult with capacity and he's dying and he told you, don't touch me, don't touch him. In many vascular patients dying, bleeding, and the patient saying, leave me. You can't touch him. It's not like in our own countries, but if he had lasting power of attorney and I went to another case and I have coma, he can say, okay, operate on him or don't operate, as long as he got lasting power of attorney for health, not for financial, but for health. Okay. And mental capacity advocates. There are no mental capacity because you are saying consent form 4 because the patient got no capacity because he cannot what? What is the definition of capacity? He can what? No, not decision. He can understand, retain, communicate his informed decision. Okay. So understand, retains the information, able to communicate his decision for consent. Okay, so if he can't understand, then this is no capacity. If he cannot retain, there is no capacity. If he cannot communicate, so patient is very well done, but he can't see, he can't talk, he can't listen, but he is able to understand. So what is the value? He can't give me this, so he got no capacity. Okay, so what are the mental capacity advocates? They are people by the government asking you as a doctor why you did this. So they have the legal rights to ask you about whether your investigation was the right thing to do at this point. Okay. Respect form in situ. What is the respect form? Like DNA CPR is like, you know, the patient background and the future wishes. And if DNA CPR do not resuscitate me while I'm having deterioration. And escalation plan and ceiling of care. What is the escalation plan and ceiling of care? It's maximum treatment. Excellent. So there are types of treatment. Active treatment. Amber. Amber means you are not certain about this patient in his deteriorated state is going to come back or no. So in amber, it's you give IV fluids, but you don't give antibiotics, or you give IV fluids and antibiotics. In palliative, you don't give anything. Just give best pain relief, just sit tight until the patient dies safely. So palliative team, pain team, and best nutrition, best pain relief, and keep the patient die safely. This is called palliative. Ceiling of care is, and escalation is, if the patient deteriorates, what is the maximum? Like there are level 0, level 1, level 2, level 3. Level 3 is ITU. But what if this patient is frail, elderly, having a lot of comorbidities, renal failure, chronic kidney disease stage 4, and he got duodenal perforation? So would this patient get benefit from ITU? No, because he will not come back. And if he came back, you are causing more pain to him. So not for ITU. This is ward level based care patient, not for ITU, not for HDU. It's ward level care based care. So this is called TIP plan or escalation plan. TIP form is the escalation plan. Is that important? Yes. So when the consultant is aware about that you read something related to the UK practice, he will easily forgive a lot of mistakes for you and give you the chance to pass this exam to be registrar and to start your career. So apparently this is not heaven, not golden tips, but they are important to be in your mind. So I will ensure respect for in situ escalation plan, ceiling of care, and DNA CPR if available. If that patient is for active treatment or active conservative treatment or end of life care pathway, or only for ward level care, for ITU admission or no, and if he is palliative, I will speak to palliative team, pain team, nutrition team. Okay, so apparently what we have spoken is Royal College book. Okay, so this is the Royal College base, what's called, this is, yeah, CRISP, yeah. So immediate management, you have decided that these patients are critical and well, so you have done ABCD approach, and then you have reviewed charts, including medication, antibiotic charts, news charts, fluid balance charts, antibiotic charts, whatever. Then GB records and notes of the patient, ensuring to have a look at the recent scans, recent endoscopies, frailty and performance status and comorbidities, full history taking, full physical exam, and then available results. Please say what are the lactate, what is the result of ECG, and what is the result of HP, ECG, lactate, and chest X-ray. So ECG, chest X-ray, lactate, HB. That's four points important. Then you will say, after finishing ABCD approach, I will check available results and I will keep ABCD approach until the patient stabilizes. So what if the patient is not stable? Keep doing ABCD approach. While I'm resuscitating him, I will ask for CT abdo-pelvis with contrast, and then decide and plan. Patient stable, then okay, patient is for his normal investigation, normal nutrition, stepping him down from ITU to ward or from ward to discharge him. So remove his tubes, convert IV fluids to eat and drink, convert IV antibiotics to oral antibiotics, drains and the tubes removal, and that's it. Diagnosis required now overnight, yes. So you need specific investigation. Don't say ultrasound. No, CT abdo-pelvis with contrast. You are requiring an osmotic leak. Patient desaturating post-abdominal, post-orthopedic surgery, you are requiring PE, so CTPA. Okay, don't think about, so as long as the patient is unstable, you need diagnostic investigation tool for definitive management, which will include medical, surgical, or radiological, or medical, radiological, and surgical at the end. Okay. Oh, read about how to do it in the CRISP. Is easy peasy. You just do, hello, how are you? Airway patient. So patients communicating, I'm going to proceed with B. In B, yeah. In patient what? Indoor, yeah, inward, inpatient. Yes. If the patient came with appendicitis, because last exam one time, one of your colleagues told me I did the CRISP. I told him patient with appendicitis. Why you do CRISP? You just assess him and you do your CT abdo-pelvis. If clinically appendicitis, you don't need to have CT. If she's lady and young, you are requiring tube ovarian stuff, just and the clinical appendicitis lab appendix, lab or plus or minus open appendix, plus or minus proceed, and keep your gynae handy, and ultrasound, plus or minus ultrasound if you want. So this patient will be post-operative in ward. Yes. This is your father, and you are going to examine him. Ask him, can I confirm your name? This is not 1 million question, $1 million question, or even 1 million Pakistani rupee or Egyptian pound. It's, I know where you came from. That Oh, he's in ward, you know him. It's not appropriate to ask him. That's not good. That you will ask our patients every time. So I have a patient here in ward. Every day I go, can I confirm that this is correct patient? WHO checklist. What is the WHO checklist? They mark the site of the surgery, but they say, is the site marked? You see, it's marked. But keep checking is vital and it's essential. Okay. I don't think you need anything rather than practicing and reading this multiple times. And it was recorded, Dr. Khalid and Dr. Muhammad Farid and Dr. Lenovo, uh, you know, this laptop. Okay, thank you so much. Assalamu alaikum. I will post it to the group. Yes, boss. Yeah. Yeah.